All right, everyone, welcome. We are at 34 people, so we're good to start. Blondie, got it. Okay. So really excited today, as Saima Aslam just noted, she thinks this is her first high round. So I think for a lot of people, this will be the first time you hear from her, and also a really exciting trial that she's been involved in. So I'm going to introduce her. Dr. Saima Aslam is a professor of medicine in the Division of Infectious Diseases and Global Public Health at UCSD and is the director of the Solid Organ Transplant Infectious Diseases. She is internationally recognized in the field of transplant infectious diseases and is currently the chair of the COVID-19 task force for the International Society of Heart and Lung Transplantation and a member of the executive committee of the American Society of Transplantation ID Community of Practice. She has authored over 80 peer-reviewed papers, including several practice guidelines for the transplant ID community. She's involved in multiple multi-center research studies involving transplant patients, including serving as the site PI for 3 HOPE clinical trials involving liver and kidney transplantation in patients living with HIV. We also just learned that she is teaching her daughter to sew so that she can be a productive member of society at some point. We're so excited to have Saima here with us. And I'm going to turn it over to you. I will also, Saima, though, try to give you about a 10 to 15 minute heads up at the end to save time for discussion.
Sounds perfect. Okay. Well, thank you very much for the invitation to speak. And yes, I don't know why, but we've never, I guess, done this, or I haven't done this before with our HIV community. So I'm excited to tell you about what's been going on in the setting of organ transplantation for people living with HIV. And so my goal really is to talk a little bit about transplant, outcomes of people in HIV without transplant, and then the studies that we are enrolling patients at here at UCSD. So conflict of interest noted here. So just kind of to set the stage regarding the state of transplantation in the United States. So this was data I pulled up last night. So we have this organization called UNOS, which is the United Network of Organ Sharing, and basically it keeps track of all transplants within the United States. So as of yesterday, there were 106,775 patients, so 106,775 patients that were awaiting an organ transplant. And just to give you sort of an idea of the mismatch, so far in 2021, we've done only 31,361 transplants, and this was as of September. And then the number of organ donors, including with deceased and living, this year in 2021 thus far has been a little over 15,000. So there you can see, there's a huge mismatch of number of people waiting, which is constantly growing, and the number of people that are actually getting transplanted. So despite that mismatch, over the past decade, there have been a number of innovations to help increase donor utilization and try to get every organ that we can, and also increase rate of donation. And so for 2020, despite a year of being hit by the pandemic, it was a record year. It was the 10th record year in a row for deceased organ donations. We did a little over 33,000 organ transplants, and this was an increase of 6% from donors in 2019. And so part of the innovations to increase donor utilization include things like ex vivo organ perfusion. So and we do this at UCSD as well. This is a set of lungs. And the goal of ex vivo organ perfusion is to take sort of marginal organs, whether they're lungs, heart, kidney, or liver, and sort of optimize them ex vivo so that instead of discarding an organ, we're actually able to use it. Other things, and we've been doing at UCSD, is the use of hepatitis C infected donors. And our center was one of the earlier pioneers that started doing this as clinical practice in 2017. We do what's now gaining a lot of acceptance, donation after circulatory death, as opposed to sort of the traditional, which was donation after brain death. The use of last year, actually COVID infected donors as well. And this was really cool. This is from Toronto, the use of drones to transplant organs. So, no matter where you are, where, somebody is able to donate an organ, and it was transported by drone, and these were actually lung transplants. And then what I'll focus on today is the use of HIV positive organ transplants as well. So just to kind of again set the stage, HIV patients make up anywhere from 1% to 2% of all ESRD patients in the United States, and that's estimated to be about 10,000 patients. And then when we look at liver failure, and I kind of mentioned kidney and liver mainly because these are the commonly transplanted organs in the setting of HIV. And so sort of focusing on these two. And then liver failure, end-stage liver disease is a common cause of non-AIDS related death in the setting of HIV. The numbers are significantly less than that of end-stage renal disease, especially now in the era of DAAs and, us treating and curing HCV infection. But it's estimated that about 1% of liver transplant candidates in the US have HIV. So when we look back sort of, historically, for patients that have HIV and are on dialysis, they generally have poor outcomes when they are maintained on dialysis. So this is a study, a US RDS database. This is a national database of all, CKD and ESRD patients in the US, has about 1 million patients. And this study is a little old, but does show, I'm not sure if you, okay. So this study does show that overall survival for people on hemodialysis or intermittent HD has been improving, though in general still remains less than people that do not have HIV. So this sort of looks at a timeline that in general, you could see that it was 38% survival, in 1990 to 54% in the late 90s to 74% in 2000. And then in general, HIV positive versus negative, there's still, a marked difference, unfortunately, in terms of ESRD outcomes. And then when we look at end-stage liver disease as well, again, there are not that many patients, but this is a small study looking at 58 HIV positive patients who had end-stage liver disease compared to HIV negative patients. And then you can see, at least in this study, how many underwent MELD was significantly, not how many underwent MELD, how many underwent liver transplant based on MELD was significantly lower for HIV positive patients, and their waitlist mortality, about half of them actually died while on the wait list waiting for a liver, compared to death on the wait list for somebody that was HIV negative. So in general, outcomes for this group of patients is very, it's poor. In particular for those that have high MELD scores or are co-infected, and about half of these deaths are due to infection and sepsis. So the first landmark trial, and this is just, this is HIV negative organ donors for kidney transplantation in HIV positive patients. So this was published in New England in 2012. It was a study. This is a US study. It was done at 19 centers, and there were 150 patients that had underlying HIV that underwent kidney transplant. And all recipients had CD4 counts of greater than 200. Their viral load was undetectable. They were on a stable ART regimen. And in general, the studies show, and SRTR here is a scientific registry. It's a transplant registry in the US that basically looks at outcomes. And so in the study, they had 150 patients underwent transplant, but they compared them to the registry outcomes to see if there was a difference. And basically, patient survival for HIV infected, is this small dotted line, was very similar to what's in the registry for all patients. That's the SRT1, SRTR. They also just compared outcomes of HIV infected patients to those of kidney transplants that occurred at age 65 or greater, just because this was, considered still standard of care. And they noted that HIV patient outcomes were actually better than those, survival was better than older patients that underwent transplant. However, when we looked at graft survival, meaning kidney function over time, that was not as good as the SRTR data, and actually was similar to those of elderly patients or older patients that underwent transplant. The thing that was most marked in this study was the high rate of rejection, and that sort of points to that earlier slide showing that survival was fine, but kidney function was not that great. And about a third of patients in the study of 150 patients had an episode of acute rejection. And so, this was significantly higher than those that were their controls in the SRTR database. And about half of these episodes were actually severe rejections. It wasn't just, any or mild rejection, there was severe rejection. In multivariate analysis, factors that were protective against having rejection were higher tacrolimus levels. So having, good immunosuppression levels, the use of living donors rather than deceased donors, and then also if they had higher CD4 counts. So this is a different study, and this just looks at using, U.S. registry data, just looking at all HIV infected versus uninfected, and looking at outcomes of patients that underwent kidney transplant. In general, showing that when you had HIV monoinfection, outcomes were actually very similar to uninfected. However, when you had co-infected patients, their outcomes were worse than the registry database. This looks at the outcomes of liver transplant from that same registry database. So patients with underlying HIV that underwent liver transplant. In this study, there were 180 such patients between 2002 to 2011. And in general, their outcomes were actually worse than HIV uninfected patients. And so they even looked at sort of an era difference, and there does seem to be an era difference. But in general, co-infected patients, again, actually had the worst outcomes for liver transplantation. This just gives you an idea of just the numbers of HIV positive patients that are undergoing transplant in the US. And so you can see, by far, kidney is the highest, is the most commonly transplanted organ. Certainly have liver transplant, and then, significantly less heart, lung, as well as combined organ transplant. And this line here, hope implementation, is when the study is looking at the use of HIV positive organs for transplant took off in the US. But, we still were transplanting a fair number of patients before then as well, but with HIV negative donors. So this just gives you a little bit of a timeline in terms of, firsts or notable firsts. 1988 is when the US passed what's called the National Organ Transplant Act. And this act really set the framework for organ transplantation in the US. And it developed sort of our federal, framework of sharing organs across state lines and all that kind of stuff. It also made it illegal to sell or buy organs, which was not the case before then. And the other thing that it did actually was make it illegal to actually use organs from donors that had HIV infection. So the earlier pioneers in terms of HIV transplant actually it was South Africa. So this was just the data I showed you. So just using HIV negative donors to transplant in HIV positive. However, the first HIV positive to HIV positive transplant was done in South Africa. So this was actually 2010. And then 2007, the Swiss Federal Act and a couple of others in Europe actually allowed the use of HIV positive organs for transplant. But Europe in general hasn't had that many numbers, and it's sort of more had small case series or cases that have been published. Based on the experience from South Africa in 2013 is when we passed our HOPE Act, which allowed the use of HIV positive organs for transplant, and the first such transplant actually was in 2017. So you can see, our first step really was just transplanting people that had HIV. We then moved on to using HIV positive organs, and now there's actually interest in mismatched donors and recipients as well. So the first experience of HIV positive donor to HIV positive recipient is from South Africa. This is Dr. Elmi Muller, who's a transplant surgeon in Cape Town, who sort of was a pioneer in this area. Her first paper was published in 2015 and described outcomes in 27 recipients. All of these had well-controlled HIV, so CD4 count greater than 200, undetectable viral loads. And the reason I think, why this was started there really was, a clinical need. So in South Africa, versus here in the US, the amount of patients with HIV is, significantly higher when you look at overall population. They also had high rates of ESRD. And at that time, and I'm not, to be honest, sure if it's changed now, but at the time, patients with HIV that had ESRD could not undergo dialysis at a dialysis facility. And so transplant, was a truly life-saving option for these patients. So she transplanted 27 patients with HIV positive deceased donors. And these deceased donors either were ART naive or they were on a first-line ART with undetectable viral load. They excluded donors that had sepsis, active TB, WHO stage 4 disease, or abnormal kidney function. Recipients were excluded if they, actually this is the opposite, if they were on ART for less than 3 months, or if they had a history of AIDS defining opportunistic infection, and then all patients underwent standard immunosuppression. And in general, she showed excellent graft survival as well as patient survival. And you can see this is, almost a little 2 years out in terms of follow-up. She more recently published, her group published a follow-up study with greater number of patients. So these are now 51 patients that underwent HIV positive to HIV positive kidney transplant. Again, and this now you can see outcomes. These are up to 10 years post-transplantation in general are excellent, both for graft survival and patient survival. In this study, they also tried to look for episodes of donor superinfection and found 2 probable cases in which it may have happened. But all these patients were treated and did not have any clinical impact of that infection. So based on South African experience, Barack Obama signed the HOPE Act in 2013. And mainly the big sort of effect was, or the goal was, to use organs from HIV positive donors for transplanting to HIV positive candidates, but only under the setting of quite tightly controlled and approved research protocols. This went into effect in 2015. And so since then, in 2016 really is when the first organs were transplanted. So this just looks at data from UNOS, sort of 5 years of the HOPE Act, looking at number of transplants performed under this act. You can see the first couple of years, it was a slow start. 2018 and 19 were good years. This is not all of 2020, so this was just till September, but in general, estimated to be on par to 2019. So through 2020, you can see that at that time, 24 hospitals had performed total of 223 transplants. Of these, majority were kidneys, 170, and 53 were liver transplants. As of November last year, 30 hospitals are enrolled, within the organ donation system to accept HIV positive organs for transplant. Okay, so a study that sort of first came out with this HOPE trial was initially a pilot study. So this is a prospective multi-center pilot study looking at the use of HIV positive deceased donors to HIV positive recipients for kidney transplant. And this pilot study was conducted at 14 centers from March 2016 through July 2019. There were a total of 75 kidney transplants. Only 25 of these were actually donor positive, recipient positive, compared to 50 that were donor negative, recipient positive. So, the standard of care arm, with a median follow-up of 1.7 years. In general, graft survival and patient survival was very similar. There was, between these 2 cohorts, there was not only difference, there was no difference in graft survival, but overall kidney function or mean GFR was actually similar as well. There were no differences in relation to HIV breakthrough or infectious hospitalizations or those due to opportunistic infections between the 2 groups. The one difference they noted, and it's sort of more of a trend, not statistically significant, but probably related to sample size, was the rejection issue. So they did see that the patients that had an HIV donor positive organ actually had higher rates of rejection. So 1 year, 50% had rejection compared to those that received HIV donor negative. And then when they looked at this sort of same issue with the kind of induction that was used or immunosuppression, they noted that immunosuppression was significantly, the type of immunosuppression was significantly related to rejection. So when we use standard immunosuppression, which are depleting induction, so usually the use of thymoglobulin, the rate of rejection was less. There were I think 2 centers in the study that did not use sort of standard immunosuppression, their local protocol called for alternative agents when they had HIV positive candidates. And it was those two centers that kind of drove the increased rate of rejection. And so at our center, we use standard immunosuppression, and we haven't noticed this to be an issue. So a few other things have sort of come out so far. This is a study that looked at donor-derived superinfection. This was, again, just from the pilot studies. So this was the initial pilot studies of both kidney and liver transplant. I did not show you data for the liver transplant pilot because it's not published yet, but I think it should be over the next couple of weeks. So in this study, they basically had 14 kidney, 8 liver transplant recipients. And in general, the take-home message, one of sort of the fears of, when we first started doing this was this concern for HIV superinfection in the setting of, donor positive and recipient positive. And there was no evidence of superinfection in the study. One patient had breakthrough infection 3 years after transplant, but it seemed to be due to ART non-adherence. And in that patient, there were no donor sequences that were detected. So the main chunk of what I want to talk about were sort of the two big studies that are ongoing, the Hope in Action under a U01 from NIAID. So the first study we've actually completed now. So this is a kidney transplant study. The goal here was to have 100 patients that received HIV donor negative transplants and 100 patients that received HIV donor positive transplants. And so the last patient was enrolled September 2021. And this was conducted at 31 centers. So this is completed, but still undergoing follow-up. So the goal is to have at least 1 year of follow-up on these patients. I don't unfortunately have results from this trial. And then there's the liver trial is ongoing. And this actually started in 2020 and still enrolling. And this just gives you numbers of how many people have been consented so far. This data is as of last year, actually. I don't have more updated numbers. The target enrollment for this study is actually 80. So our goal is 40 patients that received donor negative liver transplants versus 40 that received donor positive. For the liver study, there are 19 clinical sites in the US, 2 in California, UCSF and UCSD. So, North and South California are the only places for the liver sites. Oops. So in general, both of these trials have similar enrollment and schema in how we're enrolling patients and also of our goals. So in general, for both of the kidney and the liver trials, it's open to anyone that has underlying HIV and is a transplant candidate at that center. We have actually pretty lengthy informed consent process, and they have to meet by law an independent advocate. So somebody that we've identified that's not part of our research group, but associated with transplant, that actually interviews the patient after the consent process to determine that there was no coercion and that the patient does understand, what they're signing up for. So once they meet all eligibility criteria, they're enrolled. Once they're enrolled in the study, there's sort of a button you click within the donor allocation system, just saying that they're willing to accept HIV positive organs. And so once that happens, and anytime an HIV positive donor comes up, our patient that's been enrolled sort of comes into match runs, for that organ donor. So we don't, and this is something I explain to my patients, we don't determine what organ, a patient will get. So depending on whatever is, the best organ that pops up for them, whether it's HIV positive or negative, that's what they proceed with. So for patients that in whom we accept an HIV positive organ, they go into the HIV positive donor and recipient positive arm. We anticipate that there will be a lot more HIV negative offers. And so if an HIV negative offer is accepted, that's when they actually get randomized to either being in the full study, so HIV donor negative, recipient positive, or they get randomized basically to a separate registry in which, patients don't actually have to go through the entire study, not criteria, but the study protocol in terms of biopsies and blood samples and things. So these patients, we will basically just follow up for analysis, for survival and graft analysis over time. So that's not included in the sample size of these. So again, for kidney, the goal here was 100 versus 100. For liver, it's 40 versus 40. So the objective of this trial, the primary objective is to determine if an HIV positive organ transplant is safe in terms of major transplant and HIV related complications. Secondary outcomes, and I'll sort of go over these details, are to go through a list of other outcomes between HIV positive and negative donors. And then there are a number of exploratory outcomes as well. So the primary endpoint is a composite endpoint. So a composite event looking at all-cause mortality, graft failure, serious adverse event, HIV breakthrough, virologic failure, or an opportunistic infection. So there are a number of secondary endpoints, and some of these I sort of alluded to earlier, but we're looking at things like patient graft survival, serious adverse events, rejection. We're looking at, in terms for the kidney patients, it's GFR, and then similar assessment of liver function for liver transplant patients. Outcomes in terms of complications to the organ of transplant, looking at HIV disease progression. So they have pretty frequent follow-up, both of HIV as well as CD4 count over time, with a maximum follow-up of 4 years and minimum of 1 year. And then just other secondary endpoints, looking at development of resistance, opportunistic infections, tumors, donor-specific antibodies, and then that composite endpoint. There's also exploratory endpoints that are built into both of these trials, looking at incidence of HIV superinfection, both within blood as well as tissue. We usually get a number of lymph node and organ biopsies as well, trying to assess latent reservoir. And there are also some quality of life measurements and other patient-reported outcomes via survey. So what happens is when an organ offer comes up, it is my job and that of my other transplant ID colleagues. We go through the deceased donor history in detail. So we have what's called DonorNet, in which you can assess or try to get information regarding the donor, in terms of how they died, any positive blood cultures, CD4 count, HIV viral load, if they've been in treatment, trying to reach out to their primary care physician or HIV physician to get information regarding what drugs the donor was on. But the goal of all this is, one, really to feel comfortable proceeding if we're able to come up with a good ART regimen, so that the regimen we have the patient on will treat not only the patient's HIV, but also the donor's HIV. So that's sort of one important aspect. We go through the donor also in detail to really assess for opportunistic infections and neoplasms. If they have viral loads, we'll look at that. In both of these protocols, hepatitis C positive donors are allowed. They were not allowed initially when the studies were first approved by NIAID, but with an amendment, with growing use and excellent outcomes with HCV positive organs, they're allowed. So co-infected donors are allowed as well. And this, a few other things. And the other thing I didn't mention earlier, so in general, false positive HIV under the HOPE, not under the HOPE, but under the original sort of legal framework, prohibiting the use of HIV positive donors, prohibited the use even of a false positive donor. And so with this study, we're able to use donors that even if we think they're false positive, in which case they're assigned to the HIV negative donor arm. For recipients, it's really, criteria, whatever is the criteria at a local transplant center, they must meet. In general, recipients have to have well-controlled HIV, so CD4 less than 50, CD4 greater than 200, but viral load less than 50. The cutoff for liver for CD4 count is 100 because they tend to be pancytopenic. And these are studies only for deceased donors. If they have a living donor available, then they're not, eligible to be transplanted as part of this study. In general, we go through detailed history of opportunistic infections, making sure they've had appropriate therapy and there's no evidence of active disease. So we talked about how there are 2 trials. Unfortunately, I do not have results of either of these 2 trials at this time because they're both blinded, and we still have a year to go of follow-up before we can release the results. So what I did want to talk about were a few sort of other papers that have been published through the UO1 HOPE trials, sort of additional studies within this patient population. So looking at donors that have false positive HIV, the willingness of our patients to accept HIV positive organs. There have been a few papers I will not talk about as well, including COVID, but also talk about patient experience. And then, what do our donors, what do HIV positive donors in the US look like? So the first thing I think that was most surprising and was unknown prior to the start of the study was actually just the number of false positive donors. And sort of the take-home message of this study was that 35% of livers that were transplanted from HIV positive donors and 46% of kidney were actually labeled HIV positive, but were actually false positive. So, this was sort of an unexpected finding and sort of this big gift in that these were organs that previously, prior to the HOPE Act, could not have been transplanted. And so even though they were, truly HIV negative organs. So under the HOPE Act, these organs were allocated and were used by patients. The other thing of interest is the willingness to accept HIV infected and what's called increased infectious risk donors among patients. So this was just a survey of patients, and this had 116 participants from 9 centers. In general, median age was 55, most were male, and most were Black. Of the patients in this study, only less than 50% actually were enrolled within a HOPE protocol. But the majority of these patients, 84 and 87%, were actually very interested in accepting an HIV positive organ. If for patients that were enrolled or surveyed in a center that already had a HOPE trial in progress, those patients actually had higher rates of willingness to accept, probably because their transplant teams had discussed it with them earlier. So in general, there seems to be, in this small subset of people, a high willingness to accept HIV positive organs for transplant. And this is just a survey, just looking at patients' experience once they had already undergone HIV positive donor transplant. So these were 35 interviews from 22 recipients. And one interview was done sort of at the time of within 3 weeks of transplant surgery from a HIV positive donor. And then they had a second interview about 3 months later. And in general, so this is what I like. This is just, a patient quote of, their experience and how they thought it was awesome. Participants that accepted HIV positive donor organs, and this included both kidney and liver, they did it because they thought it was beneficial for them. And in particular, the main benefit actually was a reduction in waitlist time. In general, they had good experiences with the consent process and the trial process. There were a few patients that were concerned about stigma and wanted to make sure their information remained private. And there were a few patients actually who thought that HIV positive transplants were not eligible to receive HIV negative organs, which was concerning, which certainly is not true. But in general, the benefits that patients, appreciated or looked for, or that made them accept an HIV positive organ, was a reduction in waitlist time. So in California, average waitlist time for a kidney is 6 to 10 years. One of the first patients that we transplanted at our center waited 6 months and got an HIV positive organ. So it's a huge mismatch with the amount of time somebody will spend on dialysis, if they were sat and kind of waited for an HIV negative organ. So that's, I think, the biggest benefit. Again, sort of with that is the opportunity to get transplanted. A number of patients, including those that I've consented here, are very interested in contributing to science. They also feel that if they are transplanted earlier with a shorter waitlist time, they will actually be healthier at the time of transplant. And they're interested sort of altruistically, able to help others on the waitlist. So briefly about the national landscape of HIV infected donors in the US. This is a study that was done looking at donors from March 2016 to March 2020, had 92 donors, of which 58 were HIV positive, 34 were false positive, This represents almost 100% of all US HOPE donors. These 92 donors donated 177 organs. excuse me, I think of this. I may sneeze, in which case I'm going to mute myself. Okay, so this is just a map of where these organ donors came from. The majority really are in the South. So we've got, and I guess I didn't go into this, but in general, when we look at organ donors, we have what's called, the US is divided into various regions. So instead of looking at it state-wise, we look at it by region. So California contributed quite a bit actually here, Texas, and then we have a lot from Florida and other countries in the South. This just looks at the number of hope donors, of HIV positive hope donors during this time period. Again, the first couple of years, it wasn't a whole lot, and then it sort of took off after that. And this really just had, in this study, just a few patients at the beginning of March, at the beginning of 2020. So this table looks at the differences between patients that were true HIV positive versus false positive patients. In general, the true positives were older than the false positives. The other thing that stood out was for true positive HIV, they had higher rates of hepatitis B core antibody positivity, CMV positivity, and then syphilis compared to the false positive donors. And this just looks at the true positive, so N of 58. Most of these patients actually had known diagnosis, so 71% had a known diagnosis of HIV. For 24%, the diagnosis was actually made at the time of organ donation, since all donors undergo HIV testing. Risk categories are noted here, so sort of about 43% MSM, but then you also have heterosexual sex and IV drug users, and then percent of sort of others. 64% of HIV donors were on ART, about a quarter were not. Median CD4 count was 194. So, you know, sort of like half and half or above or below 200. And then you can see the HIV viral load at donation. So HIV genotyping was performed in 47 samples, and 42% had at least one drug resistance mutation. So the most common mutations that the donors had, about a third had NNRTI, 19% had NRTI, 4% had integrase inhibitor, and 2% had PI mutations. 6 of these patients had multi-class drug resistance mutations, and 2 of these were actually, the donors were virally suppressed. So kind of moving just a little bit onwards, I told you how the main study looking at kidney transplantation between HIV positive and negative donors has concluded enrollment. So in order, and by law though, we're still required to use HIV positive organs through research protocols. So in order to now, you know, still continuing to use HIV positive organs, we have a third study, which is a single arm sort of observational cohort. And this, the goal here is really just to provide access to at least, you know, over 300 plus candidates with HIV that were enrolled and are still waiting for transplant. And so through this, they can get an HIV positive organ, and they can still get HIV negative organs as standard of care, not part of the study anymore. And so we're hoping, you know, with this study that we can minimize reporting burdens as time moves forward. So the goals of the study are still somewhat evolving and pending. In general, we want to look at optimal immunosuppression, you know, obviously long-term survival and kidney function, and sort of look at a few other outcomes that are noted here, as well as some basic science studies involving blood samples in these patients. There's also a clinical trial looking at the use of HIV positive living kidney donors. UCSD is not a site for this. And so in this study, the big issue really is the donor. And it's for any living organ donor, the well-being of the organ donor is paramount. And so the concern here is if they have underlying HIV and they, you know, they're doing well, they give up a kidney, do they have long-term effects, negative effects in terms of kidney function over time? So this, you know, is a study that's enrolling patients as well in the US. And then this was interesting, and it hasn't been done in the US. I think we're very far from that. But this is a case report of a living donor liver transplant from an HIV positive mother to her HIV negative child. And this is a case report from South Africa. and apparently, they've had about a year of follow-up, and they noted that for the baby, the child that got the transplant, they noted seroconversion in the recipient, so then the HIV negative recipient, but they noted that by a year of follow-up, the HIV antibody titers were minimal and approaching undetectable. And they also noted that they were unable to detect any HIV in the recipient at any time point since surgery, but the recipient has been on ART, and the follow-up in this paper was about a year only. So this is just us, our transplant surgeons. This was our first HIV positive organ transplant, which was August 2019. So far we've transplanted 5 livers and 5 kidneys under the HOPE protocol. And this actually includes HIV, HCV co-infected donors. And that's a paper that we're writing up. Actually, there are about 25 such organ donors within sort of the UO1 networks, including both liver and kidney. The ones that we did at our center had excellent outcomes with no issues in treating either the HIV or the Hep C. So a thank you to the HOPE team, and these are all the different centers that are involved in this study. It's being led by Johns Hopkins. Dori Segev and Christine Durand are the 2 PIs of the UO1 trials. And these are our team here at UCSD, all of whom have been incredibly helpful, in particular, the study coordinators. I didn't go through sort of what we all do to our patients, but these trials have involved back table, OR biopsies of the recipient and the donor. And some of these have been, at 10 p.m. at night and 2 a.m., etc. So it's been quite a lot of work, actually, even though it's a smaller number of patients. But I will end here, and I think we should have time for discussion. Thank you. Oops, stop that.
Saima, thank you so much. What an interesting talk. And yes, you've given us plenty of time for discussion. I can read through some of the questions that came up. The first one was from Alan McCutcheon. I'm interested in the independent advocates required by the trial. Who fills this role? What are their goals? And what experience have you had with their impact?
Yeah, so the independent advocate was something that was strongly, it's a requirement of the trials, and it's really put in place by the NIH. There was a lot of hesitancy initially to promote, enrolling patients for this trial, and concern for potential coercion of patients. So at our center, every center has an independent HOPE advocate that we're required by law to have. So at our center, our advocate is somebody that actually works with living donors. So she's not part of our trial. And so her normal job is to meet with living donors to make sure they're not coerced. And so in this trial, her job then, there's this sort of a checklist that she goes through with each patient. One is to understand, that the patient understands the goals of the trial. Also to verify the patient does not feel coerced or is pressurized, and also to reinforce that, being in the study is voluntary and we would still transplant them even if they said no. So things like that. And in general, experience has been excellent. I had one patient who once the HOPE trial, the independent advocate met the patient, came back to me with questions, and that was to really do with drug medication costs. So if they had, an HIV positive donor and we had to change the recipient's ART regimen, who would pay for that? So that was really the question that arose. But in general, I think the experience has been excellent. I think moving forward, eventually, I think we would get rid of that as a requirement per se. But currently, yes, we have one person that does it both for our kidneys and livers.
Thank you, Saima.
Okay, I'll just read the next question so everyone can hear it from Nettie Aldis. I'm interested to know, I'm interested in how to identify more potential HIV positive donors. I think that most patients living with HIV think they can't donate, so may not have a donor card or tell family members that they are interested.
I think that is an amazing point, something I did not touch upon. But I think at some point, I feel like I had a discussion with Miley a few years ago before COVID about how we should do, a project and really try education. But yes, I think this is something that all of you as HIV providers can discuss with your patients, that, any and all of them are potential organ donors. But I'm unaware of a specific sort of outreach within that community, at least within San Diego. But I think it's a huge opportunity for improvement.
Should we tell them to, hi, thank you. This was a great talk. I really appreciate it. This is Nettie. Should we, tell them to fill out a donor card and, sort of what things to do? I love any opportunity to remind my patients that, they can participate in, the same things in life that others can.
Yes.
So I actually think that knowing this would be kind of an emotional thing to know for patients, even if they did or did not participate. So I'd like to share it with them, but then I don't know what to tell them to do. So fill out a donor card and tell their families.
Yes, I think so. Yeah, any and all of them. So definitely, I think just letting family members, household members know that they're interested in being an organ donor is step one. Certainly when they go for driver's license renewal, or you can just go to the DMV website and you can just, there's a button you can click and say, I want to be an organ donor. But those two usually are enough. So even if somebody's not signed up to be an organ donor, but if they pass away and they have the opportunity to be one, if their family members are aware of that wish, then generally most proceed with organ donation.
There's another question from Tyler Lonergan. Has quality of life been studied pre and post transplant? My patients who have received organ transplants struggle with the side effects of anti-rejection meds, infectious complications, and the burden of monitoring.
Right. So we are doing that as part of the these U01 clinical trials. So all patients actually at the time of enrollment have a quality of life questionnaire. When they come in for their transplant, but prior to surgery, they have another quality of life questionnaire and sort of various time points. I do not have results of that, but it is something that we are studying. Yeah, I mean, I will add in, we've sort of done that for our Hep C infected donors, recipients that underwent transplant from Hep C infected donors. And most patients actually had a great experience. I mean, there are increased medications and things, but in general, the quality of life after transplant, in particular for kidney and liver transplant recipients, is much better than pre. Yes, there are, medication issues, but especially for people with ESRD, not being on dialysis is a huge improvement in quality of life. And they go from, 3 times a week visit to once a week visit. So it's actually reduced burden in terms of office visits. And for liver people as well, I mean, most patients undergo liver transplant in the US and California actually have males of like 30 and higher, which are very sick patients. And so once they survive that initial sort of hump, which is the first 6 months or so, most patients do have actually excellent quality of life post-transplant, not to mention just longevity.
Our fellow Katie Riggs asked a great question. What do you think is the reason for the increased graft rejection? HIV immune dysregulation, underlying disease leading to, I actually don't know what the TX is, to
transplant.
To transplant, okay. Or possibly lower. I see TX, I see treatment. Let me do that again. Okay, so what is the reason for the increased graft rejection? HIV immune dysregulation, underlying disease leading to transplant, or possibly lower TACRO levels, or some other reasons?
So the biggest contributor actually is this fear initially, and I think we've moved past that now, that HIV patients, if we give them the same immunosuppression as HIV negative people, that they will have significantly higher opportunistic infections and ID complications. And so the earlier studies with higher rates of rejection also show that people with HIV get sort of non-standard immunosuppression. So our standard after kidney is thymoglobulin induction, in which it really lowers your counts. And most patients that, and it used to be at our center too when I started, our our protocol for HIV patients that underwent transplant actually was not to use standard immunosuppression because of that fear of infectious complications. So I think now that we've learned enough and we've moved to regular immunosuppression as we would with an HIV negative, hopefully, that makes a difference, but so that's something we'll see in the upcoming trial once those results come out. So in the pilot study data that I showed you, in which 30% of people had rejection after kidney transplant, most of that was because those people also did not have standard immunosuppression. The other issue that we talk about a lot are drug interactions. So in particular, protease inhibitors have significant drug interactions with tacrolimus and other immunosuppressive agents. And so with that, if you get low TAC levels, you'll have an episode of rejection. And so our current goal, and for one or two people, we've been unable to switch them, but is to always have patients on non-PI based regimens. So if that's something you can do pre-transplant, that's wonderful. For some of my patients, I change them over. Generally, we've been using Biktarvy a lot recently post-transplant. And so if so just minimizing chances for drug interactions so that you do not have suboptimal immunosuppression levels. I think the HIV superinfection was also a big concern. So far, we haven't really seen that. And again, the study, the bigger study that just completed, I don't have data from. So that's, pending. And maybe next year I can give you an update because we should have that published. But the issue, so it's really just the basic reasons of why they have high rates of rejection. We're not, immunosuppressing them well enough. And I think other things are significantly lower on the reasons for that. And then we haven't had enough long-term follow-up to know about HIVAN in the setting of donor-positive kidney transplant.
Thank you. That was really helpful. Also, regarding Nettie's point, how about increasing uptake on getting people onto the donor list, I'm imagining people would also be afraid of disclosure after death or disclosure, to maybe possibly family members at the time of death that it would come out that they were donating an HIV positive organ. I'm assuming we could comfort patients and say that that would not happen. I'm assuming that the same kind of protections would be in place for people even after death.
I think so. I don't know the answer 100%. I think that is correct, but I don't know that for sure. But in general, I feel like there's a lot of opportunity for us to talk to our patients, both in terms of, being organ donors, but also, in terms of just the HIV community, for you guys, and you guys know this, but people, outside of UCSD, for example, other HIV providers, that HIV positive patients, remain generally excellent candidates for transplant if that's something that they need.
Does anyone else have any other comments or questions? Feel free to unmute yourself if you'd like to. We're just getting a lot of praise in the chat. I think, this is, again, a great talk reminding us that, something came up. I was just going to say, reminding us again that our patients really can do, anything and everything. Why do you think there's so much false positive HIV?
I don't know. That's the only answer I have. I mean, it was certainly a surprise. And a number of the false positives actually were, and we see this actually even now, are neonates. And I don't know enough about testing, and maybe you could tell me why that is. But yeah, it was a surprise, I think, to everyone, and very unexpected that almost half of HIV positive kidney donors were actually false positive, but a number of those were actually pediatric.
The pediatric testing, and I'm not a pediatric HIV specialist. I don't think we have them on. But testing is much more complicated in neonates, and I'm not sure what testing was used, but HIV-1 DNA has to be used. So I don't know what testing was actually what was being used standardly, because that can occur. But I don't know enough about the testing algorithm to know why, but that would be my thought, that that tests were being used that may not, that where we see more false positives and not as sensitive and specific as the HIV-1 DNA.
Yeah, so all the confirmatory tests were done at Hopkins by Western blot. So that's why, but then you find out, 2 to 4 days later that the donor was false positive.
And then they're excluded from the trial. Is that what happened?
No, so they're still part of the trial.
Okay.
But then they get allocated to the HIV negative.
Got it.
Donor, yeah. But in the past, we could never have used them. So OPOs, don't do Western blot. So generally, when you test organ donors, you usually have about 24 hours or so to do all your testing. Sometimes you send things off, but you have to have a decision of whether you're proceeding with transplant or not. So a number of things that we order pre-transplant are not actually available at the time of organ offer. So the HIV, positive testing, that now everyone gets NAT testing actually. But then by law, they also have to have antibody testing. So the NAT testing results are available within hours. And so that has to be there as part of the organ offer. But the Western blot was done as part of the trial. And so that result we would find out after the transplant had even happened. And they're like, oh, well, I guess that was false positive. So it's, yeah.
Well, and that's interesting too. We've been, as we do more and more testing of low risk populations, we see a lot of false positives. And just with the CDC algorithm, this is, just in people not exploring transplant, we don't even use the Western blot anymore. Like that's been completely taken off what we use. So that's interesting to me, as opposed to proviral DNA, which is the sort of the best test that we have right now to really help us confirm HIV or not. So it's interesting that the Western blot is what's being used. And I don't know if anyone has any thoughts. I see there are lots of other people on the call who may have comments on that. Or they're not commenting. The Western blot is used for everyone or just for the neonates?
Oh, everyone. So as part of the trial design, all donors actually have, like, I think 40 mils of blood sent to Hopkins. And then when we take organs, we do back table biopsies on those organs as well. But yes, so all the HIV positive donors get the Western blot test, as well as sequencing and all kinds of other things.
No one seems to want to unmute and comment.
Okay, I don't know enough about that to make any comment other than what I said.
Yeah, no, I'm intrigued by that, and it seems based on what I know slightly outdated, just because we know that the Western blot can be accurate and pick up things that it may not, but that aren't actually there. Anyway, very interesting. Okay, and then Katie also said, also surprised that only 71% of true HIV positive donors had prior diagnosis. I thought we were doing better than that with testing. Yes. Yeah,
I mean, we have a number of donors that, the diagnosis was made basically after death. Yeah, and I see Francesca's comment, not at the borders. I mean, we don't really have that many of these patients that were, I'd say, immigrants. I mean, the majority of these patients actually are donors. I think about 70% or so were Black. Yeah, but most of them are along the South.
All right, well, it's the top of the hour. Okay. This was thought-provoking and interesting. And obviously a lot of questions. We're going to have you back as once you're further along with the trial and can start to give us some data on stuff. So
thank you very much.
We really appreciate you joining us and dropping off your daughter earlier.
Yes. Okay. Thank you, everybody, and continue please to refer patients if you have anyone, and please remember PI switch to non-PI pre-transplant. Thank you.
Thanks for the
Bye-bye.
data.